Good morning, everyone. Hope all of you are in best of your health and staying at home and staying safe. We shall be continuing with our lecture on burns. What are the major determinants of outcome of a burn? So the first one is percentage surface area involved that we have already discussed. It is determined by the Lund or Brother chart or the Wallace rule of 9. Then comes the depth of burn, such as partial thickness burn or full thickness burn, presence of an inhalational injury, and involvement of the respiratory tree. This will be discussed subsequently. Circumferential burns, which are usually around the chest, upper limbs, and the lower limbs. It has a tightening effect which causes the loss of vascular supply to these areas, and especially in the chest, it restricts the respiratory movements. It affects the respiration and breathing of the patient. And then obviously patients under age of 2 and over 60, that is extreme of ages, are very important. So now let me give you a very brief talk on the effects of hot gases, smoke and steam. Inhaled hot gases, what do they do? They can cause supraglottic airway burns and laryngeal edema. Inhaled steam can cause supraglottic burns and loss of respiratory epithelium. Inhaled smoke particles, they can cause chemical alveolitis and respiratory failure. Inhaled poisons such as carbon monoxide can cause metabolic poisoning. How do we recognize the potentially burned airway? There will be a history of being trapped in the presence of smoke or hot gases. This history can be given by the patient or any person or any personnel that has brought the patient to the hospital. He will give you the history that the patient was being trapped in a closed room and there was too much smoke or hot gases in the room. There will be burns in the palate or nasal mucosa, and there will be loss of all hair in the nose. Patient might have deep burns around the mouth and neck. Any person trapped in a fire for more than a couple of minutes must be observed for the signs of smoke inhalation, and these are the 3 signs that I have already told you about. All the hospitals all over the world have a criteria for admission to a burn unit, and the criteria includes suspected airway or inhalational injury, any burn likely to require fluid resuscitation, any burn likely to require surgery as the definitive treatment or management, patient with burns of any significance to the hands, face, feet, or perineum, patient whose psychiatric or social background makes it inadvisable to send them home. Any suspicion of non-accidental injury. Now, what is a non-accidental injury? It includes suicidal attempts or murder attempts. Any burn in a patient at extreme of ages. Any burn with associated potentially serious sequel, including high tension electric burns and concentrated hydrofluoric acid. In the initial management of a burned airway, elective intubation is the safest. Delay can make intubation very difficult because of the swelling and edema. Emergency cricothyroidotomy may be required if intubation is delayed because of the edema. Management of the burn patient has 2 major aspects. First one is the pre-hospital care and the second one is the hospital care. The principles of pre-hospital care are: ensure the rescuer's safety, that is, the person who is risking his life to save the life of a burn patient should be equipped with all the necessary equipment and protective gear to keep himself safe first. Second, we have to stop the burning process. Check for the other injuries like head injuries, vascular injuries, any prominent or obvious fractures. Cool the burn wound to dissipate the heat, because as long as the temperature in the tissue is above 44 degrees centigrade, the injury continues. We have to prevent hypothermia, we have to prevent the wound contamination, and we have to prevent the evaporative heat loss. Otherwise, we are going to lose our patient. We have to give the patient oxygen. Now comes the hospital care. The principles of managing an acute burn injury are the same as an acute trauma. We have to follow the ATLS protocols. We have to maintain and control the airway. We have to maintain the breathing, and we have to maintain the ventilation of the patient. We have to secure 2 large bore IV cannulas for resuscitation of the patient. We have to check the neurological status of the patient, and we have to remove all of the clothes of the patient with the environmental control so that our patient should not slip into hypothermia. We have to give fluids, and we have to control the pain, because all of the burn patients, they experience extreme pain because they can feel each of their cell in the body or the burn part dying and burning. So what can be done for the pain control of a burn patient? Narcotics such as morphine is used as the first line treatment because it is a very strong painkiller. NSAIDs such as ibuprofen and diclofenac, acetaminophen, codeine, short-acting benzodiazepines such as midazolam to enhance the sedation and provide anxiolysis. We have to give antibiotic cover to the burn patient and tetanus prophylaxis. Antibiotic cover is it is important because the patient has lost a considerable part of his skin, and skin is the largest organ of the body, and it provides protection against almost everything out there in the environment. So we have to give the antibiotics that are specifically working against Pseudomonas, Staphylococcus, Klebsiella, and Enterobacter species, because these are the commonly affecting organisms. Now comes the fluid resuscitation. Intravenous resuscitation is required for any child with a burn greater than 10% of the total body surface area and 15% total body surface area for adults. How much fluid should be given? It is calculated by a formula which is known as Parkland's formula. This formula specifically calculates the fluid that has to be replaced in the first 24 hours. It includes total body surface area multiplied by the weight of the patient in kgs multiplied by 4. Half of this volume is given in the first 8 hours and the second half is given in the subsequent 16 hours. Ringer lactate solution, Ringer lactate fluid, is the most commonly used crystalloid. Crystalloids are as effective as colloid for maintaining the intravascular volume. Fluid resuscitation in children is a bit different. The fluid that we give to children is mostly dextrose saline. Why do we need colloids for resuscitation of a burn patient? It is because plasma proteins are responsible for the inward oncotic pressure that counteracts the outward capillary hydrostatic pressure. Without proteins, plasma volume would not be maintained as there would be edema. Proteins should be given in the first 12 hours of burn because therefore, before this time, massive fluid shift would have occurred and the protein would leak out of the cells. So we have to make sure that if we have to give proteins, we have to give the proteins in the first 12 hours of the burn. Most common colloid-based formula is the Muir and Barclay formula, which is 0.5% multiplied by percentage body surface area burned into weight. This gives 1 portion. And 1 portion is to be given in each period. So now we are giving our patient crystalloid and colloids. How do we know that our resuscitation is enough for the patient or if it is not sufficient for the patient? So the monitoring of resuscitation is very important, and the key to monitoring of resuscitation is urine output. Urine output should be between 0.5 to 1 ml per kg body weight per hour. If the urine output is below this, the infusion rate should be increased by 50% of what you are giving already. So up till now we have discussed how do we generally resuscitate and manage the burned patient. Now what about the part that is burned? How do we take care of the burned part? Loose, devitalized tissue should be gently trimmed away, and this process should not cause pain or bleeding. Blisters, if the patient has blisters, we have to leave them intact or we have to delay their removal. An intact blister usually indicates a superficial partial thickness wound which will heal spontaneously within 3 weeks. Cleansing the wound is very important. For cleansing and to remove the residual dirt, the wound can be gently washed with room temperature normal saline or sterile water with a mild bland soap. There are certain topical agents that we can apply on the wound to accelerate the healing. That is silver nitrate solution, mefenide acetate, silver sulfidizing cream, povidone iodine ointment, gentamicin ointment. What is the importance of dressing in the burned patient over a burned area? It basically serves 3 purposes. It absorbs the drainage, that is the exudate that comes out of the burned surface. It provides protection and a measure of isolation of the wound from the environment. It decreases the wound pain. Superficial partial thickness burns with intact epidermis do not require topical medication and they do not require any dressing. Superficial first degree and superficial partial thickness, that is second degree burns, they do not require surgery. Any deep partial thickness or full thickness burn, except those that are less than 4 to 6 centimeters, they need surgery. Deep encircling burns of the limbs and trunk require eschorotomy, which is giving incisions to loosen up the tightened tissue around the chest or the limbs. In chest, circumferential burn, they restrict the breathing movements, they restrict the ability of the ribs to move, so they cause respiratory failure. We have to give releasing incisions in the chest so that the patient can breathe normally. And in the limbs, same way, if there is a circular burn, circumferential burn, it will affect the vascular supply of the limbs and it can cause permanent loss of the limbs. So we have to do something that is life-saving, limb-saving, that is eschorotomy. Now, what type of surgical procedures can we perform? Early excision and skin grafting to achieve wound closure. It has shown very good effects. It reduces the infectious complications, it reduces the length of hospital stay, and it improves the survival in burn patients of all ages. Tangential excision, it removes the burned skin while preserving the underlying viable tissue, and we have to give a split skin graft over that area afterwards. Full thickness burns require full thickness excision of the skin. The burned part is excised till we reach the viable fat or the viable muscle. Thank you so much for your patience and for understanding. If you have any queries, you can contact me. You have the group and you have your WhatsApp group as well. You can contact me on the WhatsApp or on the Facebook page. Thank you so much for today.